Hello, everyone, and welcome to our module on the ventricles and sinuses. So let's start by talking about the ventricles, which are fluid-filled structures or fluid-filled chambers in the brain. And the fluid that they're filled with is the cerebrospinal fluid. There are 4 ventricles in the human brain, 2 lateral ventricles, and then one called a third ventricle and another called the fourth ventricle. And the ventricles can all communicate with one another, and they are also continuous with the central canal of the spinal cord, where you can find cerebrospinal fluid. And so if you look at this drawing on the slide here, it shows you all the ventricles of the human brain. So the left and right lateral ventricles are shown here. They are very large and they have a shape like the letter C. The third ventricle is right here. It has this sort of funny shape and it sits in the middle of the C of the lateral ventricles. And then down here in front of the cerebellum, that's where you find the fourth ventricle, which has a diamond shape. And then also notice that the ventricles can communicate with one another. So the interventricular foramen shown here, it's also called the foramen of Monro, allows fluid to drain from the lateral ventricles into the third ventricle. And then the cerebral aqueduct, shown here, allows fluid to drain from the third ventricle down into the fourth ventricle. And then finally, you can see that the fourth ventricle drains down into the spinal cord where it's continuous with the central canal. And you should be aware that the ventricles are usually fairly easy to identify on images of the brain like CT scans and MRIs. This is an MRI here, and you can see the 2 lateral ventricles very easily right in the middle of the image. Okay, let's talk in a little bit more detail about cerebrospinal fluid. So cerebrospinal fluid is a clear, colorless fluid. This is a tube of it in the picture here. You can see it almost looks like water. And it acts as a cushion for the brain. By having it present in the ventricles, it supplies mechanical protection and acts as a shock absorber. It also does some other things like circulating nutrients to different parts of the brain and helping to remove waste. Let's talk about how cerebrospinal fluid is produced. So you should know that the structures in the brain that make CSF are called the choroid plexuses. There are 4 of these in the brain. There's 1 in each ventricle. And each plexus is a network of capillaries surrounded by specialized cells called ependymal cells that produce and secrete CSF. Now, once CSF fills the ventricles, eventually it will be absorbed by structures called the arachnoid villi. They're called the arachnoid villi because they are finger-like projections or villi of the arachnoid matter, which is one of the layers of the meninges that I talk about in other videos. So these little finger-like projections, these arachnoid villi, extend into sinuses of the brain, especially the dural venous sinuses, like the superior sagittal sinus. And we'll talk more about these later. And so these arachnoid villi absorb the CSF, and then once it's been absorbed from the sinuses, it drains into the venous system. So the balance between production of CSF by the choroid plexuses and absorption by the arachnoid villi is what determines how much CSF will be circulating in the ventricles of the brain. When you do your OBGYN rotations and you perform ultrasounds on women who are pregnant, sometimes in the developing baby, you will see a choroid plexus cyst. This is simply a cyst growing out of one of those choroid plexus structures. These can be detected in utero by ultrasound. They can be a normal finding, but they're also associated with chromosomal abnormalities like Down syndrome. And so when one of these is discovered, it sometimes leads to a workup for chromosomal problems in the baby. The major pathology associated with the ventricles of the brain is hydrocephalus. This refers to dilation of the ventricles with excessive volume of CSF inside the ventricles. And this is displayed in this image on the slide here. This is what normal ventricles might look like. Right here, we've got hydrocephalus, where you can see the ventricles are much, much bigger. We break down hydrocephalus into 2 subtypes, communicating and non-communicating. In communicating hydrocephalus, the ventricles can communicate with one another. The problem is not an obstruction between the different ventricles. The problem is insufficient absorption of CSF by those arachnoid villi. This creates an imbalance where the amount you're being produced isn't being absorbed properly, and so you get too much CSF, and that starts to dilate the ventricles. The other form of hydrocephalus is called non-communicating, and it's called this because the ventricles can't communicate with one another. There's some blockage or obstruction to flow. And just like the ventricles are fairly easy to identify on brain imaging, hydrocephalus is also fairly easy to identify, especially when it's severe. And so this is an example of a CT scan showing massive hydrocephalus, and you can see that the 2 lateral ventricles are enormous compared to that image that we saw a few slides ago. Before we can talk in more detail about the causes of hydrocephalus, we have to briefly talk about intracranial pressure, or ICP. This refers to the pressure of the cerebrospinal fluid within the skull. The normal range is about 10 to 20 millimeters of mercury in adults. It's less for children and pediatrics. And there are a couple of ways this can be measured. Commonly, it's measured by a lumbar puncture, where you insert a pressure catheter into the spinal canal and you measure the pressure of the CSF. There are also other special techniques that can be used to estimate the ICP, things like catheters that can be inserted into the spinal canal. There are various sensors. There are also some techniques by ultrasound, MRI, and CT to get an estimate of the intracranial pressure. The lumbar puncture is probably the one you want to be super familiar with. This is the common way to directly measure the pressure of the CSF in the spinal canal, which is transmitted up to the brain because the spinal canal is in communication with the ventricles. So when you measure that pressure by lumbar puncture in the spinal canal, you're measuring the pressure inside the skull. Okay, so now let's start to talk about causes of hydrocephalus, and we'll begin by talking about communicating hydrocephalus. So the major cause of communicating hydrocephalus is decreased reabsorption of CSF. This happens when there's scarring of those arachnoid villi from meningitis or a prior subarachnoid hemorrhage. As a result, the villi are not absorbing CSF normally, and you get a buildup of CSF and high pressure, and that causes hydrocephalus. It's communicating because the ventricles can communicate with one another normally. Very rarely, you can see communicating hydrocephalus from increased CSF production. This can happen in children who have rare tumors called choroid plexus papillomas that produce CSF. And so these children can present with a mass in one of the ventricles and clinical signs of elevated ICP and hydrocephalus. And then finally, there's a special condition we're going to talk about shortly called normal pressure hydrocephalus, where all the ventricles can communicate with one another, there's no obstruction, and the pressure of the CSF is not elevated, but nevertheless hydrocephalus occurs. So in communicating hydrocephalus, like from prior meningitis or subarachnoid hemorrhage where there's scarring of the arachnoid villi, you will get high amounts of CSF in the ventricles because CSF is not being absorbed normally, and this will raise the ICP. And so this will cause clinical findings of elevated ICP, things like headache and papilledema, which is shown here in this image. The hallmark on CT scan is dilation of all the ventricles. Because the ventricles can communicate with one another in this condition, they all dilate. And if this is left untreated, potentially the ICP can get so high that you can have herniation of brain tissue, which I talk about in other videos. So the key clinical scenario to know about for communicating hydrocephalus is a patient who had prior meningitis or subarachnoid hemorrhage, who now presents with headache, papilledema on eye exam, and the ventricles are enlarged on CT scan. This collection of findings should make you think of communicating hydrocephalus from poor CSF absorption. Another cause of communicating hydrocephalus is normal pressure hydrocephalus, or NPH. And it's called normal pressure hydrocephalus because you have enlarged ventricles on imaging, just like you expect in hydrocephalus, but the opening pressure on a lumbar puncture is normal. This is an image of what it looks like on the screen. You can see the ventricles are dilated, and what happens when they get that dilated is they compress the corona radiata, which are descending cortical fibers that carry motor function information down to the spinal cord. And so when you get compression of those fibers, that's what can lead to the clinical features of this disorder, which we'll talk about in a minute. We don't really know why the pressure is normal in this condition, even though hydrocephalus occurs. The suspected mechanism is that there's impaired absorption of cerebrospinal fluid, but there is some compensatory mechanism in the brain that prevents the development of high pressure when you do a lumbar puncture and measure the opening pressure. So normal pressure hydrocephalus leads to a classic triad of clinical features, and the three elements of the triad are dementia, urinary incontinence, and abnormal gait. The gait is classically a wide-based gait. Patients are often described as having gait apraxia. This means they have difficulty initiating steps for walking. Also, patients are often said to have a magnetic gait. This is where they act like their feet are stuck to the floor and they have trouble lifting their feet to begin walking. And this triad is usually remembered by the mnemonic wet, wobbly, and wacky. That's the classic triad of NPH. This condition is important to diagnose because it resolves with removal of cerebrospinal fluid. You can either do this once by a lumbar puncture and draining some of the CSF, or you can place a shunt called a ventriculoperitoneal or VP shunt that drains CSF to the abdomen. But both of these things are going to lower the pressure inside the brain, and they're going to improve the symptoms of normal pressure hydrocephalus. And this is important because most people who have dementia have an irreversible cause like Alzheimer's disease. NPH represents one of the few reversible causes of dementia. Some of the others are things like B12 and thiamine deficiency, and you don't want to miss those conditions and assume someone has an irreversible cause of dementia like Alzheimer's. Okay, now let's talk about non-communicating forms of hydrocephalus. These occur when there's a structural blockage of CSF flow within the ventricles. And there are lots of different etiologies for this: anatomical, congenital, tumors, infections. But there are sort of four key causes you ought to be familiar with as a medical student. I've listed them here, and we'll go through each of these one at a time in the next couple of slides. So aqueductal stenosis refers to stenosis or narrowing of the cerebral aqueduct, also known as the aqueduct of Sylvius. This aqueduct drains the lateral and third ventricles into the fourth ventricle. So when you have stenosis, there will be a blockage for the drainage from the third ventricle into the fourth ventricle. As a result, the lateral and third ventricles will become dilated, but the fourth ventricle will be normal or small. And it's super high yield to remember these facts here. They're going to want you to know the anatomy of this condition for your board exams. And so if you look at this drawing on the slide here, these are the lateral and third ventricles here. They drain through the cerebral aqueduct into the fourth ventricle down here. So if you have a narrowing right here, the higher ventricles like the lateral and the third are going to become dilated, but not the fourth ventricle. So why do people develop aqueductal stenosis? Well, this can occur as a congenital narrowing. There's an X-linked condition that is transmitted to boys that can lead to aqueductal stenosis. You can also see this in children when there was an intrauterine infection before they were born. So mothers who develop rubella or CMV or toxoplasmosis or syphilis, these things can be transmitted to the baby and cause inflammation of the brain, and sometimes those children are born with aqueductal stenosis. And the presentation that you should be looking for in board questions is a newborn baby or a small child who has an enlarging head circumference. That is one of the clinical features you see in children born with an aqueductal stenosis. Another cause of non-communicating hydrocephalus is a colloid cyst. Colloid cysts are cysts that develop in the brain. They're benign and slow-growing, and they're common at the roof of the third ventricle. So if we look at this drawing on this slide here, this is the roof of the third ventricle, and that's where you find the interventricular foramen, also called the foramen of Monro. So potentially one of these cysts can block CSF flow through the foramen of Monro. When this happens, the lateral ventricles can't drain into the third ventricle. CSF cannot exit the lateral ventricles because the foramen of Monro connects the lateral ventricles to the third ventricle. So this is going to lead to non-communicating hydrocephalus, and the pattern of ventricular enlargement is going to depend on whether the cyst is blocking flow from both lateral ventricles or just one. If there's unilateral blockage of just one lateral ventricle, then you can see enlargement of just one lateral ventricle. But if both lateral ventricles cannot drain into the third ventricle, then you're going to get enlargement of both ventricles. Usually the third and fourth ventricles remain normal. And these are the anatomy details that you want to keep straight in your head about this condition for your board exams. And colloid cysts causing hydrocephalus are very rare, but when they do happen, they often occur in young adults in the age range of the 20s to the 50s. Okay, next let's talk about a Chiari-2 malformation, which is another cause of non-communicating hydrocephalus. So this is a congenital malformation of the central nervous system, and it results in downward displacement of the cerebellum. In particular, the structures that usually displace downward are the cerebellar vermis and tonsils. So the vermis is a midline structure in the cerebellum that I talk about a lot in the video on the cerebellum, and the tonsils are small rounded lobes on the inferior surface of the cerebellum. Sometimes the brainstem, the medulla, is also involved. And so these structures displace downward through the foramen magnum, and potentially they can compress the brainstem, leading to problems of brainstem nerve deficits. And when this happens, there will be non-communicating hydrocephalus. Basically, the lateral and third ventricles aren't going to drain normally into the fourth ventricle. And that's because the fourth ventricle is being obstructed by the downward displaced cerebellum. So you'll see enlarged lateral and third ventricles, but a small compressed fourth ventricle. And the underlying cause of a Chiari-2 malformation is believed to be a neural tube defect that occurs during embryogenesis. And so if you understand that a Chiari-2 malformation is believed to be a complex form of a neural tube defect, then it's easy to remember that Chiari-2 malformations are strongly associated with myelomeningoceles. Myelomeningoceles are a type of neural tube defect that I talk about in another video, and they result in the failure of the spine and meninges to close around the spinal cord. So as a result, you get the spinal cord and the meninges outside of the spine. This is a picture of what it looks like on the slide here. You can see that you don't have the spine closing around the spinal cord, and as a result, the meninges and spinal cord nerves are all outside of the spinal canal. When children are born with this type of neural tube defect, a myelomeningocele, they almost always also have a Chiari-2 malformation. It's super high yield to remember that. And in fact, when children have a myelomeningocele, the major cause of morbidity is not the myelomeningocele, it's hydrocephalus from the Chiari-2 malformation. And that's because the Chiari-2 malformation obstructs fourth ventricular outflow, just like we talked about in the last slide. And then our final cause of non-communicating hydrocephalus is a Dandy-Walker malformation. This is another congenital malformation. It's a developmental anomaly of the fourth ventricle. In this condition, there's hypoplasia or agenesis of the cerebellar vermis, and there are also cysts of the fourth ventricle, and those cysts lead to hydrocephalus. This condition is very easy to identify in imaging because the fourth ventricle is enormous with a very small cerebellum, and then there's obstructed flow through the fourth ventricle, and as a result, you see enlargement of the lateral and third ventricles. And so if you look at this image on the slide here of a child with a Dandy-Walker malformation, you can see that the cerebellum is very, very small here, and there's this enormous fourth ventricle back here. That's the finding that makes these malformations very easy to identify. And so affected children have hydrocephalus. This usually leads to macrocephaly, which is an enlarged head circumference. They have delayed development. They also have motor dysfunction, problems with crawling and walking. And here are a couple of other images of Dandy-Walker malformations. Hopefully you can recognize that these fourth ventricles are enormous, and that makes this condition very easy to identify on imaging, even at the med student level. And then the last condition related to the ventricles of the brain that I'll talk about in this video is hydrocephalus ex vacuo. This refers to enlargement of all the ventricles, but it's not due to the buildup of CSF. It's caused by atrophy of brain tissue, making the ventricles appear larger. This occurs with aging to some degree as the cortex atrophies, but it's much worse in patients who have some type of neurodegeneration disorder like Alzheimer's. And so what you get in hydrocephalus ex vacuo is increased size of the ventricles in proportion to increased size of the sulci. So recall that the lobes of the brain have these little bumps called gyri, and in between the bumps you have these area called the sulci here. So when there's cortical atrophy, these sulci are going to get larger, and so if you see enlargement of the sulci together with enlargement of the ventricles, then that's hydrocephalus ex vacuo. If you see enlargement of the ventricles that's out of proportion to changes in the sulci, then that's what you see in hydrocephalus. Very important to understand this distinction for your board exams. And so brain atrophy as we age starts in the 30s or 40s, but it progresses as we get older. And as I said, especially in patients who have Alzheimer's or some other disease where the cortex degenerates, they can have massive enlargement of the ventricles, not due to a buildup of CSF, but caused by hydrocephalus ex vacuo. Okay, so that's everything I've got on the ventricles of the brain. If you do the associated questions with this video, we have clinical examples of all the different disorders I've talked about up until now. What I'm going to do at this point is switch gear and start to talk about sinuses in the brain, and I'll start by talking about dural sinuses. So dural sinuses are venous channels. You can think of them sort of like fancy veins, but they travel through the dura. That's why they're called dural sinuses. And they drain blood from cerebral veins. They also receive cerebral spinal fluid from the arachnoid granulations, those arachnoid villi we talked about before. And they take this blood coming from veins and the CSF, and all that fluid drains into the internal jugular vein after it leaves the dural sinuses. And so this is a zoomed in picture of some of the dural sinuses. This is the superior sagittal sinus right here. You can see it's drawn just like a vein, and that's kind of how you can think of it, like a venous channel. And then this is an enlargement of it up here. You can see that there are arachnoid granulations within the sinus, and those arachnoid granulations or arachnoid villi are going to drain the CSF into the sinus, and that's going to travel through the sinus down into the internal jugular vein. So there are a number of major dural sinuses, but some of the important ones you should know about are, first of all, the superior sagittal sinus, and that's because that's the one that receives cerebrospinal fluid like we talked about earlier in this video. And then the cavernous sinus is another dural sinus that has a clinical syndrome associated with its dysfunction. So let's talk about that now. So the cavernous sinus is a large collection of veins. It's a bilateral structure. There's one on the left and one on the right, and you can find it between the temporal and the sphenoid bones of the skull. And what it does is it collects blood that's draining from the eye and the cerebral cortex, and it feeds it into the internal jugular vein. But what's special about the cavernous sinus is that within this collection of veins, there are also nerves and a portion of the carotid artery. So you can find cranial nerves 3, 4, and 6 within the cavernous sinus. You can also find the V1 and V2 branches of cranial nerve 5, and you can also find sympathetic fibers. All these nerves are traveling to the orbit through the cavernous sinus. And then, as I said, in addition, you can find a portion of the internal carotid artery within the cavernous sinus. So this might make more sense if you look at this picture on the slide here. So this web of veins right here, that's the cavernous sinus. And you can see that right in the middle of it is a portion of the internal carotid artery. You can also see that there are all these nerves traveling right alongside this collection of veins, and those are the nerves that we talked about in this slide. So because all these structures travel within the cavernous sinus, there's a clinical syndrome that can occur if you have obstruction within the sinus. So this could happen if there's compression of the cavernous sinus by a tumor or a thrombus. You can also see infections that spread to the cavernous sinus. Sometimes they cause septic thrombosis, so the infection leads to a thrombosis of those veins. These infections can come from a lot of places near the cavernous sinus, places like the face or nose or the orbits or tonsils or the soft palate. Also, as we saw in the last slide, the internal carotid artery travels through the sinus, so if it ruptures for some reason, then a fistula can form, and you can have blood from the arterial system filling all those veins of the cavernous sinus and engorging them, and that's going to lead to compression of all those structures within the cavernous sinus. So the clinical features that can occur when there's obstruction of blood flow through the cavernous sinus are summarized on this slide. So first of all, you get a headache. And why does this happen? It's because blood's not draining from the cortex through the cavernous sinus, so you get high intracranial pressure. You can also have swollen eyes or one eye, depending on whether both or just one cavernous sinus is obstructed. And that's because blood can't drain from the eye through the cavernous sinus because of obstruction. Also, those nerves in the cavernous sinus can be compressed, so you get impairment of oculomotor nerves and problems moving the eyes. The sympathetic fibers that travel through the cavernous sinus can be compressed. That can lead to a Horner syndrome. And then you can also have sensory loss because, as we talked about before, the V1 and V2 divisions of the trigeminal nerve travel in the cavernous sinus. And so these things on this slide here are what you want to remember about this syndrome, and you want to tie this back to the anatomy of all the structures that run through the cavernous sinus. And then the last topic for this video that I'll discuss are AV malformations. So AV malformations are direct connections between an artery and a vein in the brain with no capillary bed in between. And these can potentially enlarge over time, and that can lead to neurodeficits. Usually these develop in utero, but they're often asymptomatic until adolescence or adulthood when they can start to enlarge. And that can lead to things like headaches and also seizures and other neurologic deficits. One of the veins that's often involved in these AV malformations is the vein of Galen. This is a midline central cerebral vein. It's depicted here in this image. And so if it connects to an artery and enlarges over time, you can get an AV malformation in the midline of the brain, and that can lead to seizures and headaches and other neuro problems. These are usually treated with surgery once they're identified. And here's an image of the brain from a patient with an AV malformation. You can see that it kind of looks like a mangled collection of blood vessels, like arteries and veins. And you can imagine that with this growing here in the back of the brain, that can lead to all sorts of neurodeficits and headaches and seizures, and that's how these AV malformations usually present. And that concludes our module on ventricles and sinuses.